Hello, my name is Dr. Deborah Cohen, and I am the MAVEN volunteer moderator today. Thank you all for joining us and our friends at International Community Health Services for this talk about Dermatology Basics, Common Dermatoses by Dr. Wendy Huber. Dr. Huber is the former chief of dermatology at Kaiser South Sacramento Medical Center in California. She retired after more than 3 decades in practice. She has led local implementation and successful adoption of the electronic medical record, teledermatology consults, and same-day dermatologic procedural care. During the epidemic of latex allergy in the 1990s, she was the Northern California Kaiser Permanente physician lead for the creation of a program-wide latex-safe exposure control plan. In 2000, she was awarded the Kaiser Exceptional Contribution Award in recognition of her efforts. And with that, thank you, Dr. Huber, and you can begin.
Thank you so much for that very nice introduction, and welcome everyone to this talk on basic dermatology. I'm hoping that I will help you improve your diagnostic skills, and I really try to give practical treatment pearls to not only ensure successful initial treatment, but also to prevent recurrences, because so many dermatologic conditions are chronic. So there's a little bit more housekeeping. I have nothing to disclose. And as Dr. Gould went over, you can get credit for attending this session. So for our presentation topics today, I'm going to spend a little bit of time initially on topical medication basics, selection of topical corticosteroids that are appropriate for various areas that have dermatoses. And then we'll have some cases. And I do have a very long appendix at the end of this talk. And I have expanded resources for the topical medication basics there that you can find, as well as more information on the topical corticosteroids. You will get this slide deck, and so please don't feel like you need to write down what I'm saying. Most of my slides are very complete and have all of this information on them. So I just want you to kind of relax. This is an informal presentation, so please do feel free to ask questions. We will have a few opportunities for you to select a diagnosis and treatment choice. We have a few questions, so hopefully this will be an enjoyable time for you all. So topical medication basics. I think most of us are familiar with efficacy of a topical medication being dependent upon its strength and concentration. But there are 2 other factors that are really important, and I wasn't really aware of these until I did my dermatology residency. So the first of those is location of application. So let me give you an example of that. So if you have a patient that has a dermatitis, for example, on the face, 1% hydrocortisone ointment would be a perfect choice for that dermatitis typically, and you'd get good results. Now, if you then had a patient that had a dermatitis on the palms, for example, the 1% hydrocortisone would not give you that same result. That medication potency is just not strong enough. The hydrocortisone is not strong enough. And the palm and sole have the thickest skin on the body. And so it's very difficult for medications to penetrate through the outer layers, the protective layers of the skin. And so you actually need to select a product that had much stronger potency in order to get any effect. So location's important. And then vehicles are also very important. And one of my areas of interest, in addition to latex allergy, was allergic contact dermatitis, irritant dermatitis, and I became aware of all of the other chemicals that are present in the products that we put on our skin that actually can be allergenic, and they can also be quite irritating. And these are the chemicals that help to transport the active ingredient in your medication. And they're also found in over-the-counter products. So a lot of these principles on vehicles will apply to over-the-counter products that your patients are using. So we'll spend a little bit more time on that. So first of all, there's ointments. Petrolatum is an example of a common ointment. It's very greasy and occlusive. It's easily applied on the smooth skin, non-hair bearing. You'd never want to use it on the scalp. The patient would have a really hard time getting it out of the hair. And it's good for really, really dry, cracked skin. The things about petrolatum that I really like is the fact that it is not allergenic and it's non-comedogenic, even though it's occlusive, and it does not sting. And that's really important when you're giving a product or medication to a patient that has open areas of skin. It's really good when that product does not cause further irritation or stinging. Now, creams, we are all familiar. Oops, sorry. Go back. Oh dear. Sorry. Oh, wrong way. So creams we're all familiar with, and they typically have oil basis, and they add some water. They're less greasy and they're not occlusive, but these can sting. And because the water was added into this product, you have the potential for bacterial, fungal, or mold overgrowth in the product. So therefore, additional chemicals have to be added. And unfortunately, the most common preservatives are oftentimes highly allergenic when introduced to the skin over and over again. And they also are very irritating to the skin. They can cause stinging and burning. Fragrances are often found in this too, because the preservatives oftentimes have a bad odor. So it's not that the manufacturer is trying to make a product that is scented, they're just trying to hide a bad odor. But a lot of fragrances are highly allergenic in some people. So we really want to be mindful of that if you're going to use a cream base for a medication. Lotions are mainly water with some oil added, and they're less greasy. They're very easy to rub in, so patients really like them, but they don't last long. In fact, after a patient rubs it in, it's pretty much gone pretty quickly. And it can contain alcohol, which has a drying effect on the skin, but can also cause stinging. And again, we're going to see the presence of those preservatives and fragrances that can cause problems for some patients. They are easier to apply in hairy areas, so patients do oftentimes prefer them to creams and ointments. So in general, for topical medications and for over-the-counter lotions and creams, products that are marketed kind of for sensitive skin or for babies will contain fewer allergenic or irritating chemicals. And that's because the companies have done their due diligence to decide to remove those products that are the worst actors, so to speak, so that you're going to have fewer consumer complaints. Now, sometimes, even though a product is labeled that it doesn't contain fragrance, it can. And as I mentioned before, those preservatives and other chemicals can have a bad odor. So companies can wind up getting by with saying that the product doesn't contain fragrance, when indeed, if you look at the ingredients list, there are fragrance chemicals present. So if you have patients that really need to avoid fragrance, they feel that they have a fragrance allergy, or they've been told, they've been patch tested and found that they had a fragrance allergy, then they need to read the ingredient list pretty carefully. Now, oils are less stinging than lotions or solutions, and they're really, really good for the scalp, really good for patients that have psoriatic plaques on the scalp or seborrheic dermatitis. Gels I don't really like. I don't use them very often. Some of my colleagues have liked it. They contain more alcohol. They dry really quickly. Sometimes people have said, well, it's good to use on areas that are oozing. However, because of the alcohol, they can sting a lot. And there's sort of a paradoxical kind of stinging or itching sensation that can occur in some people on their normal skin when they just put a gel on. And that happens to me. So I really rarely use those products. It is common, though, to have gel formulations in acne products. And most of the time, those people don't have any issues with, other than the fact that they're, drying products, but the patient has acne. Generally, they're younger, they have very oily skin. Foams are wonderful. Unfortunately, they're very expensive typically, and oftentimes they're not on formulary, but they are very lightweight. They will not affect any hairstyles that some of your patients may have, and they're very easy to apply. Sprays I don't like, partly because I think it's hard to see where you've sprayed them and how much spray you've gotten on the skin. So that's especially important for now we're talking an over-the-counter product, but for sunscreens, it's really hard to tell where you've applied that sunscreen when you use a spray. Powders definitely have a role, especially for drying, especially in areas of skin folds, intertriginous areas. But do be mindful that if you have a lot of moisture in the skin fold, and you wind up having cracks, little macerated cracks. And you put the powder on, sometimes it can clump and it can cause a lot of sensations of friction or, kind of like almost like sand in that area. So I tend to not use those right away if people have lots of cracks in those areas and wait until things are improved. And then I'll go to powders for the folds. Okay, hopefully there aren't any questions at this point, and we'll go on to choosing topical corticosteroids. So most of you are probably aware that corticosteroids have potency classifications. Currently, there's 7 potency classifications. Back when I first trained, there was only 4, but they started splitting them into some additional groupings. But I want you to be aware of something called a group classification. So this is really important. It's how topical steroids are grouped by their chemical composition. There are 4 major groups, or only 4 groups, A through D. And this is important if you have a patient who comes to you and says, I've been told I'm allergic to hydrocortisone. I was patch tested, I'm allergic to it. I can't have anything in the hydrocortisone group. You can then consult these groupings and find another corticosteroid that would be safe to give them. Group B is got triamcinolone in it and some other corticosteroids that people could be allergic to as well. The most common corticosteroid that people are allergic to from patch testing and very large multi-center testing that they've done is hydrocortisone. It might be because this is over the counter, more people use it more often, but we have seen people be allergic to triamcinolone and also to a class 1 corticosteroid called clobetasol. So going on to potency classifications, I have a lot more information in the appendix, so I'm going to go over this very fast. Class 1 is very high potency. Then you go down to high potency, mid potency, and class 6 and 7 is low potency. Now, class 6 and 7 is the only class that you can use on the face, groin, and the skin folds. If you use the other classes in those areas, you run the risk of creating skin atrophy. One of the first signs of skin atrophy is actually persistent redness of the skin. And the patient will often think that they're not getting better, and then they'll keep applying the medication to try to make the redness go away. The next thing that you would see eventually is stretch marks or stria. And I have seen that, unfortunately, on the face on one patient, but really, really commonly in the axilla and in the groin. So you really need to be mindful of these, do not use on those specific areas. There was a product back in the day that combined triamcinolone with an antifungal. It was designed to use on the sole of the foot because you wouldn't be worried about using triamcinolone in that area. The skin is really thick. It's an appropriate use. But people started using it in the groin, and we started seeing stretch marks in some patients within just a couple of weeks. So really be mindful of any of those kinds of products, and I generally recommend not using those because the patients oftentimes will just remember that you gave it to them, it cleared their foot, now they're going to try it somewhere else, and then they could use it inappropriately. I have one other comment on 1% hydrocortisone, and that is the fact that that used to be prescription, and I'll talk about that a little bit later as we talk about some eyelid dermatitis. Okay, so do be aware that you do have a choice of different vehicles for the topical steroids that you order for your patients. For conditions where the skin is broken, I will always use ointment form. And because I'm so worried about contact allergies and I'm generally seeing a lot of patients for persistent dermatitis, we don't know what's bothering them, I preferentially just use ointments. I rarely use creams. But typically the creams in topical medication, the manufacturers are trying to put in products along with the active ingredient that aren't too allergenic. Now, if a patient is, of course, allergic to something that we think, I definitely would use the ointment as well, because I would hate for them to be allergic to some other vehicle ingredient that happens to be in the topical medication. Other point that's really interesting is the ointment form is actually really helpful in increasing the efficacy of many of the creams, and it will sometimes if many of the topical corticosteroids, and it will sometimes bump them up from being like a class 4-5 to a class 2-3. So I do recommend also that you become familiar with what's on your formulary so that you know what class 1 super potent corticosteroid you have available for you or a mid-potency one, and those can change all the time. And then one other principle with this use of topical corticosteroids, since that most of them can thin the skin, is to always try to find the least potent one that the patient, but that's still efficacious for the patient, so the patient can use it. And that's to try to minimize skin atrophy. Okay, any questions at this point? And we'll go on to cases if not. Nope. Seeing none, we'll go on. So this is the first case of the day. This is a 40-year-old. This woman recently started swimming, and she comes to me complaining about some discoloration of her lower leg skin. And she said she's getting these little white lines. The skin's looking a little bit dry. And then she has some areas where she's not sure if they're maybe looking darker. She denies any new products. The only thing that's different is that she'd recently started swimming a lot, and she was really trying to be vigilant about getting all the chlorinated water off her skin. So she was kind of taking more showers, and that's her. And then we have this gentleman who came in the same day, 50-year-old, and he's complaining of more of an ashy look to his skin. Not a lot of flaking, maybe a little bit on his socks. And again, he's saying that he's seeing all of these extra lines in his skin that are kind of lighter in color. And he's just sort of wondering what is going on. He denies any new products. He's not taking lots of showers. He did say, I mean, it is wintertime when I did happen to see this patient. And so he is in buildings that have a lot of, heat, dry heat. So my next question for you guys for the first poll is, what is your diagnosis? So do we have allergic contact dermatitis? Do we have eczema, stasis dermatitis, xerosis cutis? So I don't know if we have a poll for that.
Yes, I am trying to launch the poll.
Cool.
Are you able to see it? It
I
says
can't, but I don't know if they can.
says the poll has been launched.
I can't see it either. Dr. Cohen, if you can make me a co-host again, I can see if I can help you. And to do that, you would go over my name where the 3 dots are, and then
Okay. I'm actually, let me do that one more time.
I think I figured it out. What slide are we on, Dr. Huber?
17.
Thank you.
Oh, Dr. Cohen, if you could go and stop ending the results for the first one, that would be great. Whole result is being shared. Let me see where this is. Back. Got it. Okay. There we go. Sorry about that all. We'll give everybody about 15 more seconds to answer.
Dr. Sato says some people got kicked
Got
out.
locked out. Interesting. They're logging back in now. So sorry for this all. We'll pause. Don't worry. Well, let's end this poll here. We'll share the results, and then on the next poll, it should go smoother, hopefully.
Are we ready to do the next one then?
Can you see that first, the results? All right. And then I will stop sharing and we'll move on to the next slide.
Right, so this is what treatment do you recommend? So we have choices of A, it's mid-potency corticosteroid, like triamcinolone. B would be a low-potency one, hydrocortisone, 2 times a day, avoiding hot showers and harsh soap, and moisturizing 2 times a day, especially after a shower or bath. That would be third choice.
Give it about 15 more seconds. I can see the results and it's pretty unanimous. So we have
Good. Yay! Wonderful. So let's see, you're done with the poll and I'm going on, I hope. Not yet. Let's see. Oh, can't move.
go towards the bottom left corner that usually will appear to icon.
Oh dear. Oh, I see. Ah, somehow I can't see my cursor, but I think I'm hopefully getting it back onto my slides. Nope. Lost my cursor, which is not good.
Okay.
Let's see, I can,
Always fun. Let me just see. Okay.
screen sharing, yeah. Stop sharing. I could escape and
You try escaping and see if this works and if it'll appear
yeah, because I'm not
again.
good. So xerosis cutis, which was the majority of your diagnoses, and moisturizing is all you need. So let's just go quickly through xerosis cutis. That's breakdown of the outer skin barrier of the skin, the stratum corneum, which is also, you can sort of think of it as little bricks that are protecting the rest of the epidermis, and there's mortar in between it, which is a lipid layer, and that prevents water loss from the underlying epidermis. And so unfortunately, with xerosis cutis, you start having a breakdown of that stratum corneum barrier. More often in older age groups, and most common sites are the lower legs, dorsum of the hands. Do be mindful, dorsum of the hands, with no change in environmental things other than onset of winter. A lot of people will get cracking over the tops of their hands, and that's just due to their skin is drying out and they're getting micro fissures. Typically, there are environmental triggers for this patient. So for our first patient who was swimming a lot, she was taking frequent hot showers. She was probably trying to really soap her skin and make sure she got the chlorinated water off. The other patient, it was winter time, so heated rooms is a big problem. So anything where the humidity changes, where it becomes lower, you can see patients having issues, especially people in the older age groups. So your treatment is to restore that stratum corneum barrier function and decrease the water loss. So I like to tell people about plain glycerin soap because it's not truly like the other soaps. It's very mild and it oftentimes has fragrance added, but if you go to like food co-ops, places like that, they can often find a fragrance-free glycerin soap. There's also soaps for sensitive skin, a lot more expensive, but they are available. And then, of course, avoiding the hot showers, which kind of strips the oils off the skin, and then avoiding scratching. Now, one thing I did learn in my practice is to really ask patients, what are you trying to do to make your skin better? And in my first years of practice, I really didn't ask that. And a lot of times people don't volunteer what they're doing. But I have seen patients saying that they're putting alcohol on because they're worried that the little teeny cracks in their skin that they think are forming are getting infected. I've had them use hydrogen peroxide for that same reason. Moisturizing after shower is great. And we talked about using kind of hypoallergenic sensitive skin products. Cheapest moisturizer by far is just petrolatum. And as we've discussed, it has a lot of properties that are really nice for the patient. So that's what I generally recommend. I do tell patients if they feel that the petrolatum is too greasy, because sometimes I do get some pushback on that. And I'll say, well, at least to start with, while you're more flared, please use the petrolatum, and then you could switch to another product of your choice that you like, that you like better. But the petrolatum, if they apply it and then they wait about 15 minutes, then it generally isn't so sticky and they don't have as much trouble or concerns about clothing, getting greasy, that type of thing. Creams, always avoid fragrance. You can tell patients to look with products that have dimethicone in. Those are lightweight, they're not greasy. And then there are lots and lots of products now that have synthetic ceramides. The ceramides are similar to the lipid layer that's, forming that mortar between the little skin cells in the stratum corneum. Colloidal oatmeal also will help to improve the barrier function as well. Now, once the microfissures of the skin are improved and the skin is looking a lot better, a lot of my patients liked products with lactic acid. So lactic acid is an exfoliant, but it also is a humectant. So it will actually draw water to the skin and hold it there. It applies really smooth. It doesn't leave a greasy residue. And so a lot of my patients will like that product. It reaches its full efficacy after twice-a-day use in 6 weeks. So they have to be a little patient with it. It is more expensive significantly. And in some patients, they'll get a stinging or burning sensation, in which case, it's not the product for them. But that's one reason why I wait until the skin's improved a lot before I, suggest that the patient try that. Most important thing with cirrhosis cutis is as long as the environmental factors are present, the patient is going to need to continue moisturizing the skin, at least on a daily basis. Otherwise, it will come back. In areas with higher humidity and there's less dry heat and all that, then oftentimes patients don't need as much moisturizing. Interestingly, I had some patients that it was wintertime, they were having a horrible time with their skin, and a couple of the patients went to the Philippines, and they said within a day, their skin was totally back to normal. They didn't need moisturizers, they didn't need anything. So environmental factors are a big deal for this. Occasionally, people will get itchy skin, slightly inflamed, maybe, in which case you can consider the 1% hydrocortisone ointment that's over the counter. Okay, so this patient we had been seeing for cirrhosis cutis. Patient occasionally moisturized, not too good about that, but overall was doing well, still wintertime. But they started noticing that there was sort of a hot spot where they would find that when they were really stressed, they would start scratching. Sometimes they would wake up at night and find that they were rubbing it, and they were noticing bigger flakes, and they were also noticing some red lines. And so when I look at this, I see an ill-defined area that has some scaling. There's a little bit of pinkness, and then there are these kind of accentuated sort of pink little lines, little fissures there. So, sorry. This is xerotic eczema. So at this point, we really have gotten into more of an eczematous process. Eczematous process is where you get more disruption of the epithelium. You get more cracking, more than just micro fissures. Now you're getting more full thickness. Well, not full thickness, but you're getting thicker fissures into the epidermis. You're going to do the same things as you did for the cirrhosis, but now you've got to really tell people not to rub or scratch. And you're going to need a topical corticosteroid ointment. I really do emphasize to the patients to only apply it to the red areas. I've had patients decide to apply it all over the leg, like a moisturizer. And at this point, typically we're using things stronger than just the 1% hydrocortisone. So you certainly don't want them applying all over the leg. I've also had patients feel like once they clear something up, they want to prevent it from coming. And so then they use it all the time. So I try to make it very clear to them where to apply the medication and how often, and just a little bit is needed. So for this particular patient, we have a choice of, we could do some hydrocortisone, 2.5% ointment, could do triamcinolone, which is mid-potency, and the fluocinolone, which is high potency. I think for this patient, I'd pretty much do the triamcinolone. I would think that would work very well. If the patient was really struggling with scratching and itching, and he didn't want to take any antihistamines, anything to help with that. Then I might do the high potency, but very briefly, and I'd only give them a small amount with no refills. So I think the triamcinolone would be the best choice. I also tell the patient, you put your medication on first, because then they can see where they've applied the medicine. It will be shiny. And then they can apply, and they must apply, moisturizer all over the rest of the lower leg, because you don't want any new hot spots developing. And then as they improve, I stress tapering the frequency of steroid application. So typically I tell people twice a day, morning and night. As they're getting better, they can use the steroid at night, and they can apply their moisturizer during the day. And then as they're even better, they can go to their steroid every other night. With their, on the off days, their moisturizer would be twice a day. And then eventually they'd just be using their moisturizer. That would be the hope. Any comments at all?
You're at your halfway point right now.
Oh, good. Thank you so much.
You're welcome. And you do have a question. Do you
Uh-huh.
ever recommend occlusive dressings to maximize absorption?
I do, and we're about to get to that. So hold that question and we'll get there. Okay. So I wanted to include this slide because this is cirrhotic eczema also, but we don't see dryness, don't really see the fissuring and flaking. And that's because this patient is treating their cirrhosis and their eczema. And likely I would be interested in knowing what corticosteroid they were using, because they may have been using 1% hydrocortisone, in which case they would need a stronger corticosteroid based on this degree of erythema. But I just wanted to show this slide because we see that we don't see those kind of typical ashy looking appearance to the skin. Now, this patient is someone who had some cirrhosis, and they recently they'd lost their moisturizers, they'd lost their topical steroids, and they had this area that was getting more and more itchy, more sore, very red, oozing, and they're concerned and come to see me. So the question is, what treatment do you recommend? So we can do a poll again if you like.
Okay, can everyone see the poll?
Yep, thumbs up.
Okay. I think, looks like most everybody has answered. Oh, a few more. Okay, another second or two. And it looks like we've got a spread of results.
Ah.
Okay. Share results.
Okay. Yeah, so we're sort of split. We've got a little bit larger percentage, 42% going with the high potency and mupirocin. Then we've got hydrocortisone with the mupirocin and a small percentage doing the high potency and oral antibiotic. Okay. So thank you for the poll. And let me see, hopefully I don't have any trouble going back. Oh dear, we're having that same problem. Not sure how the problem got fixed last time because I can't move my slides. So in this particular case, I would recommend the high potency. And that's partly because, the high potency, but also with oral antibiotic. So it's a very large area, definitely is impetiginized, and the patient is really scratching and rubbing a lot. So definitely need a high potency to get quick efficacy. Hydrocortisone would not be fast enough. And so that's the selection there. You could perhaps try the mupirocin, but it's just such a large area. I would be tempted to do the oral antibiotic. Typically, we would use dicloxacillin or cephalosporin, but it sort of depends on your MRSA incidence in your facility. So but you may do well with the mupirocin as well. So, and I'm still stuck.
You try to click towards the bottom left corner of the slide deck, see if that works.
I'm trying. Don't know where my cursor
Some
is.
pajamas.
Yeah.
Okay. So what I'm going to do, Dr. Huber, for right now is I'm going to take control of your screen.
Cool.
And then just tell me to hit next and I'll do it.
Sounds good. Thank you. Oh, but I can't even do my approve for you.
Oh, rats. Okay.
You dermatitis in general is going to be characterized by broken skin. And when you have a severe dermatitis, you're going to want to be using high potency corticosteroids, typically, and that will be on broken skin. So that's fine. You can go to the next slide. Thank you. So this is another example of an impetiginized dermatitis. I just want you to be aware of the honey crusting and oozing and some pinkness around the major lesions. Next slide. Okay, so this is an interesting case. So we can't see the rest of this person's body, okay? Assuming that there's a countable number of spots so that it's not overwhelming to put medication on. This patient's complaining of some increased erythema. You can see multiple excoriations, and I will tell you that there's also some crusting and wetness. He's definitely impetiginized. For my purposes, I would do the oral antibiotic, but I would also use a class 1 corticosteroid. So we're talking about clobetasol. And this is going to take quite some time to clear up this level of erythema that we're seeing. So a lot of times we'll tell people, don't use the class 1 corticosteroids longer than 2 weeks. So, in this area of the body and looking at the spots this person has, he's going to have significant improvement at 2 weeks. There's no question of that. But if he stopped and did not use any other corticosteroids after that, he's going to flare up again. And so there's an important concept to be aware of, and that has to do with the inflammatory cascades that are started in the skin, and they take a while to improve. So let me give you a hypothetical for this patient. So we start him on an oral antibiotic. Infection clears up. I've got him on a class 1 corticosteroid like clobetasol. We're using it twice a day. He's only using it to the red spots, okay? And then at 2 weeks, he's significantly improved. He's scratching a little bit. The excoriated spots are starting to heal up, which is great, but he's not totally clear. So what are my options at that point? I'm not worried about continuing the corticosteroid, the clobetasol, for another week or 2. So I would tend to have him, give me a call so I can see how he's doing or check in with him in some way. I would continue it for another week or 2, but I would tell him, I don't know how fast he's going to get better. So as he's getting better, he can start tapering the corticosteroid. He can just use it at night and use moisturizers during the day for that week or 2 that he's continuing it. Your other option is to tell the patient you're only going to use the class 1 corticosteroid for 2 weeks, and then I'm giving you some triamcinolone. And the triamcinolone I want you to use twice a day, and then taper that as you get better. So the main thing, though, is that you just can't stop the corticosteroid cold turkey and just go to moisturizers, because he will flare up again. Any comments on this case? No. If there were more lesions, he would certainly be a consideration maybe for some prednisone, like if his total body was covered with lots of spots. So that's something as well. Next.
There is a question, one question about, can you use oral antihistamines?
Yes, you can. And I'm sorry I didn't mention that, but yes, I would do oral antihistamines as well. Thank you. Okay, next one. Oh, anyway, in interest of time, I'm going to keep going. So we talked about increasing the potency of your topical steroids. So let's say a patient cannot afford to take, to buy a class 1 corticosteroid, or it's not on formulary. So you can use lower potency corticosteroids under occlusion or under damp wraps. And this gives you some instructions for that. The main thing to know, though, is that you shouldn't occlude skin with the corticosteroid and saran wrap or for more than 7 consecutive days, and you never want to occlude an active infection. So you need to clear up the infection before you do any occlusion. Damp wraps are great. We used to do that all the time with people that had severely kind of total body erythema, and we would wind up using a topical steroid such as triamcinolone 0.1% ointment, and we'd put that on the skin, and then they'd put a damp clothing, like damp pajamas, over it, and they'd keep the damp pajamas on. You could put dry clothing on top of that, and then they would change it every 12 hours. For the occlusion With the saran wrap, you would want to change that every 12 hours as well. So
One
that, go ahead.
question. I'm sorry, one additional question for this previous patient. Would you
Mhm.
consider immunomodulators for that patient?
You know, I would need to know more about what was going on with that patient and causes. Perhaps they're having some contact allergies. So I wouldn't start out with that. I would maybe consider that later, but I really need to figure out more of the causes. So I would be still working with your topical corticosteroids, which have really fast onset of action compared to some other products like Elidel or let's see. Yeah, like Protopic or Elidel. Okay, next slide. Okay, I don't know how many of you are familiar with this. So what I am seeing is what looks like what my residents say is elephant skin, but just increased skin markings. I'm seeing a little bit of pinkness. Next slide. Here again, if we look at this wrist, we see that there's an area of ill-defined erythema. There's some areas where the skin looks a little thicker, and then we see this increase in skin lines, accentuation of skin lines. And next slide. There we go. Here again, we see very marked skin lines with a little bit of hypopigmentation and hyperpigmentation. And next slide. Very thickened skin, one excoriation, a lot of pinkness, and with really marked skin lines as we're seeing. Next slide. So this is lichenification, and I'm sorry that this slide is not formatted great, but basically this is a sign of chronic rubbing. So a lot of times patients can't really tell you how long they've been having a problem, or they really don't want to tell you that they're rubbing. And I have a lot of patients who don't volunteer that. So when I see this one, I know that they have been rubbing for sure, and I know that they've been rubbing for a very, very long time. So I'll typically say to them, if they haven't offered up that they're rubbing, I'll say, when I see patients that skin looks like this, oftentimes they're really finding that they're rubbing their skin a lot, like, even unconsciously, they'll find they're touching it. Does that happen to you? And then the patient typically will be like, oh, yes, I'm doing this all the time. And my family members yell at me and tell me not to touch my skin. So it turns out that just rubbing the skin will cause the skin to become more itchy. And I do share with my patients that they actually did a study where they had people that had normal no history of dermatitis. They had normal skin on their hands. They drew a circle on the hand. They had the patient touch the skin very lightly for about 2 minutes at a time, no more than 10 minutes for the whole day. In 3 weeks, that skin inside the circle was elevated, pink, and itchy. So most of the time when I share that with my patients, it really kind of hits home to them that they're making things a lot worse by touching. The other thing I will tell them is I will tell them that I cannot get them better unless they stop touching the skin. And generally, it will take at least 4 weeks for thickened skin to improve significantly. Depending upon the location, I will tend to go to the high potency or very high potency steroid class. And it will take a while, as we said, for them to get better. So I will wind up using that high potency class for close to 3 weeks to 4 weeks, depending, sometimes longer, but I'll see the patient back after a month. Non-sedating antihistamines can be helpful as well. Next slide. So eyelid dermatitis. So I just wanted to introduce this because 15 to 20% of people will develop eyelid dermatitis during their lifetime. Things to think about are possible allergens, and I've listed the common allergens here. It's interesting to me how many metals are in eyeshadow. Shellac is also used in lots of cosmetic products. It's sort of sticky and helps the coloration if you're using an eyeshadow to stick to the skin, but also helps other things to adhere. You're going to have preservatives. Eye preparations typically have benzalkonium chloride. That's a really common ingredient for people to become allergic to. And you can see the list goes on. Important when you have a female with eyelid dermatitis to inquire about artificial or gel nails and or nail polish, because the acrylates in those can cause eyelid dermatitis. Eyelids are really, really thin. So they're very easily sensitized by allergenic chemicals. And so you can have people that are touching other areas of their face, but really only the eyelids will break out. Certainly, you can also have cleaning products that someone's spraying and it just affects their eyes, and then soaps and shampoos. Other causes can be seborrheic dermatitis and irritant contact dermatitis as well. Less commonly are you going to see people being allergic to a topical corticosteroid. However, for the people that are allergic to corticosteroids and have eyelid dermatitis, it's generally to hydrocortisone. Next slide. So these are all my treatment tips. It's really lengthy. Given the fact that we're a little bit behind time, I don't want to read all of these off. But I do stress two things. One, again, is not touching the skin or peeling the skin. So a ton of my patients will tell me, what am I supposed to do about the flakes on my skin? Because it's flaky and I don't want to go out in public like that. I tell them to carry a jar of Vaseline with them and to apply Vaseline however often they want to, not rub it in hard, but just apply it lightly. If they have an inclination to touch the eyelid because it's itchy, they can put Vaseline on their fingertip and they can touch the eyelid. But I will also tell them that if they are peeling the skin, then they're irritating the skin further and causing new problems. Okay, next one. So this is a patient that has a new onset dermatitis that's been just in the corner of the eye. It's possible they may have had an eyeglass that had like a little metal area that was there, but most of the time it's a plastic. There are sometimes people that are allergic to plastic eye supports for their eyeglasses, but this is very recent, and you can tell it's recent because there's no lichenification. And I'm not really sure at this point, it's not onset of today because it's not edematous and there aren't any little papules. But for this, I would give the patient 1% hydrocortisone. And 1% hydrocortisone, as we talked about, it used to be prescription only. It's a very, very good product. And I've had a lot of patients tell me, well, it's over the counter, it's not going to work. And so I do let them know that when I first started practicing, 1% hydrocortisone was prescription only. And it's what I used for facial dermatitis. I never used 2.5% hydrocortisone. 1% hydrocortisone ointment was sufficient. So I do want to make sure you're aware of that because it's been over the counter now for a long period of time. Next slide. Okay, here we see that this has been going on for a while. Why do I think it's been going on for a while? Because I see lichenification of the upper and lower eyelids. I also see a little bit of edema and I see a lot of flaking. So this is some of the flaking that patients will talk about. Anytime you have a fair amount of edema to the eyelid, as that edema improves, you're going to get shedding of the outer layers in larger flakes. So I do tell patients, as you improve, you are going to get more flaking and you are going to need to put some Vaseline on that if you don't like the appearance. For this one, still 1% hydrocortisone. You could use oral antihistamines and then you'd be trying to figure out what the cause was. Next slide. All right, so this is an example again of some chronic eyelid dermatitis. Most important thing is to see that it's lichenified and it's also hyperpigmented. So a lot of individuals with darker skin types are going to get hyperpigmentation as a sign of the chronicity of this disorder. For this particular patient, I don't know what the cause was. It does look like it may have been allergic, but main thing was to see the skin findings for this. And next slide. So this is a patient where we're seeing some hyperpigmentation as well. We're seeing a little bit of accentuation of skin lines. But this patient had not had any recent flares. They hadn't had the eyelid becoming swollen. They hadn't had increased itching. So what was going on with them was the fact that they were continuing to touch the skin. And they were not stopping touching their skin. So who knows what the inciting cause was, but they were no longer contacting that trigger. They were continuing the itchiness of the skin through the lichenification process. So with these patients, they can improve quite quickly with just no longer touching the skin, and don't necessarily even need hydrocortisone, but hydrocortisone can be helpful. But oftentimes I've had kind of arguments with patients who thought for sure there must be something, and we wind up patch testing them and there's absolutely nothing. We can't find any environmental triggers, and it just turns out to be the fact that they're touching the skin. But typically within a week of no longer touching the skin, they get significantly better. Next slide. Okay, this is a good example of allergic contact dermatitis from a spray. This patient would need prednisone. 1% hydrocortisone isn't going to work. And I did have a really interesting patient who looked just like this. I saw her twice. It was a year apart each time. The first time we really couldn't figure out what caused it. We hoped it wouldn't happen again. Second time that happened, we decided to patch test her, and it turned out she was allergic to an ingredient that was in ant spray. And she had never mentioned to me any sprays that she was using because she wasn't using it around her face or anything, and she felt like she was spraying it far enough outside that it wasn't a problem, but it actually was the cause of her allergic contact dermatitis. Next case. Let's see, next slide. And one more patient again, where you're seeing lichenification a little bit and edema. Depending upon how itchy they are, you might consider a short course of prednisone, but you could do the hydrocortisone as well and antihistamines. I think, though, I would probably go for the prednisone. Next case. Okay, this gentleman comes complaining of some flaking in the eyelids. And I'm sorry, the eyebrows and also on the scalp. Next slide. This is, thank you. Next slide. Yep, this is the hairline. So you can see just a fine scale along the hairline, a little bit on the forehead. Next slide. All right, so what's your diagnosis? I think in the interest of time, oh, good, we got it up.
We do have about 4 minutes left, so.
Thank you.
Okay, can we get just a few more responses and then I'll end the poll? Okay.
Cool. Yes, seborrheic dermatitis, perfect. Classic presentation. Thank you. Next slide. My tip for seborrheic dermatitis is the use of medicated shampoos. They can be used as a facial cleanser 1 or 2 times a week. Typically, people don't like using the tar-containing shampoos in that manner. I've listed the medicated shampoos, and one thing that I've found with my patients is that they do best when they pick a couple of shampoos with different active ingredients, and then they rotate those instead of just sticking with one all the time. So if you have someone coming in who's kind of complaining, they're not feeling like it's going pretty well, then I would suggest getting a couple of shampoos with different active ingredients and seeing how that goes. Next slide. Oops, sorry. Yep, keep going. If there's erythema and scaling, back one. At the hairline or scalp, these are some recommended corticosteroids that you can use. Other choices is clotrimazole cream. Typically, that's combined with a topical corticosteroid. And then there's Elidel. Elidel takes 4 to 6 weeks to see full effects. However, it has no problems with atrophy over time. So, and it can be used once resolved 2 times a week or only when needed. So that's another choice for that. Next slide. Seborrheic blepharitis. This is a treatment that works pretty well for that.